about female reproductive anatomy. We have already covered reproductive embryology. If you have not checked that out, you can check that out in the channel. So, before starting on the reading, I'd like to do this diagram. From bottom upwards, we have vagina here. This is the fornix of the vagina. There is the cervix, which is opening into the uterus, and this is the os of the cervix. And then there is fundus of the uterus. This whole part is the uterus. This is the endometrium. This is the myometrium or muscular layer. This is the ovarian artery that is supplying these ovaries. And this is the uterine artery that is supplying this portion, the cervix and the fornix. And to the left of the diagram, this is the uterosacral ligament that connects the uterus to the sacrum. This whole yellow sheath is the broad ligament. It comprises of mesometrium, mesovarium, and mesosalpinx. So mesosalpinx is for the fallopian tubes. It is attached to the fallopian tubes right here. And mesometrium is for the uterus, and it is attached to the uterus right here. And mesovarium is for the ovaries, and it covers the ovaries right here. Then there's the ureter, the ovaries, the fimbria, which are the egg grabbers, the infundibulopelvic ligament that connects the infundibulum of the fallopian tube zygos to the pelvis. These are the fallopian tubes and the rest we have covered. Let's search what the infundibulopelvic ligament is. Peritoneal fold that connects the ovary to lateral pelvic wall and contains the ovarian vessels, nerves, and lymphatics. All right, so it connects the ovaries to the lateral pelvic wall and contains the ovarian vessels and things related to the ovary. In the lateral section, we have the ovaries right here. This is the fallopian tube connecting it to the uterus, which is slightly inverted. This is the rectum, and this is the round ligament of uterus. We were not able to see it in this diagram, but here it is, the round ligament of uterus. The bladder, of course, labia minora, labia majora. This is the urethra connecting the bladder to the outside, and this is the vagina, and then the opening of vagina with the uterus. All right, so going towards the drainage, the venous drainage and the lymphatic drainage. The left ovary or testes, so both the left and right ovaries and testes have different drainages. The left ovary or testes drains into the left gonadal vein, and then into the left renal vein, and then into the IVC. The right ovary or testes drains into the right renal vein and directly into the IVC. There is no left renal vein. The lymphatic drainage of ovaries or testes is periaortic lymph nodes. For distal vagina, vulva, and scrotum, it is superficial inguinal lymph nodes. And for proximal vagina or uterus, it is obturator, external iliac, and hypogastric nodes. So external iliac is the most important out of these. For proximal vagina or uterus, it is external iliac. For distal vagina, vulva, and scrotum, there's superficial inguinal nodes. And left gonadal vein takes the longest way because it goes to the left renal vein. Because the left spermatic vein enters the left renal vein at a 90 degrees angle, flow is less laminar on left than on right. So left venous pressure is greater than right venous pressure, and varicocele is more common on the left. This is an important clinical correlate. Why is varicocele more common on the left? Because the left side has greater venous pressure because of a 90 degrees entry of the left spermatic vein in the left renal vein. And again, ovaries and testes drain into periaortic lymph nodes, and distal vagina into superficial inguinal lymph nodes, and proximal vagina and uterus into obturator, external iliac, and hypogastric nodes. I'd like to see the words here. They will run minimally, I suppose. If there's no modal distribution in this version, I think this is an old version, and my book has the way in it. Yep, this one does not have it. Anyways. mm, Productive. So, proximal vagina, external iliac, and distal vagina, superficial inguinal. Now the ligaments. First is the infundibulopelvic ligament or suspensory ligament of the ovary. We just Googled it and it is related to the ovarian contents. It connects ovaries to lateral pelvic wall, and this one is particularly high yield. Ovaries to lateral pelvic wall, infundibulopelvic ligament contains ovarian vessels and ligate vessels during oophorectomy to avoid bleeding. All right, so what is an oophorectomy? Oophorectomy is a surgical procedure to remove one or both ovaries under general anesthesia, right? So we ligate the infundibulopelvic ligament during removal of ovaries or oophorectomy, so there's no bleeding. Ureter courses retroperitoneally, close to gonadal vessels, at risk of injury during ligation of ovarian vessel. So ureter is present. This is the mesovarium, and the mesometrium are considered the peritoneum. So the ureter courses retroperitoneally outside the peritoneum as well as inside, and it is close to the gonadal vessels. So it is at risk of ligation during ligation of at risk of injury during ligation of ovarian vessels. So we need to protect the ureter while ligation of the infundibulopelvic ligament. Then there is the cardinal ligament that is not labeled. It connects the cervix to the side wall of pelvis. So somewhere right here, the cardinal ligament. It contains the uterine vessels because the cervix is part of the uterus, so uterine vessels. Ureter at risk of injury during ligation of uterine vessel in hysterectomy. So a hysterectomy is the removal of uterus, I suppose. Yes. So ureter is at risk of injury during ligation of uterine vessels in hysterectomy. You ligate uterine vessels during a hysterectomy, and the ureter is at damage, at risk of injury again. Like there it was in the infundibulopelvic ligament of hysterectomy ligation, it was at risk of injury because of ligation of the gonadal vessels or ovarian vessels, and the uterine vessels in hysterectomy, it is at the risk of injury because of ligation of the uterine vessels. Next is the round ligament of uterus. They have highlighted round. Where is the round ligament of uterus? There it was, yes. There's the round ligament of uterus. So it connects the uterine fundus to labia majora, right? So it is a big, big connection. The uterine fundus uh, to the labia majora like this, right? Derivative of gubernaculum travels through round inguinal canal above the artery of Samson. Okay, so it is a derivative of gubernaculum. Gubernaculum was this pink structure we studied in last video, and in the females it forms the round ligament of uterus, and this they're saying it travels through the round inguinal canal, which is why round was highlighted because it travels through the round inguinal canal above the artery of Samson. So what is the artery of Samson? The artery of Samson is an artery that forms a connection between the ovarian arteries and the uterine arteries, I think, and it is the artery of the round ligament of uterus. All right, so uh, the round ligament of uterus passes above the artery of Simpson. Then there's the broad ligament, as told by its name, this broad ligament, and it says it connects the uterus, fallopian tubes, and ovaries to pelvic bone. It contains the ovaries, fallopian tube, round ligament of uterus. It contains the ovaries, fallopian tubes, and round ligament of uterus. Sorry, uterus, fallopian tube, and ovaries to pelvic side wall. That was why I was lamenting for a moment. Why did I say round ligament of uterus? So it's the uterus, mesovarium. No, sorry, uterus, mesometrium, fallopian tubes, mesosalpinx, and ovaries, mesovarium to the pelvic side wall, and contains the ovaries, fallopian, and the round ligament of uterus. See, that's where I fumble. I think I need to check this. Ligament, round ligament of uterus. So this is the round ligament of uterus. It is going backwards, and this whole thing is the broad ligament of uterus. Okay, so it is covering that as well. So it is a content. I get it now. To the pelvic side wall. And mesosalpinx, mesometrium, and mesovarium comprise the broad ligament. Then comes the ovarian ligament. The infundibulopelvic ligament was the suspensory ligament of the ovary, and the ovarian ligament connects the medial pole of ovary to lateral uterus. And it's also a derivative of the pedunculum. Ovarian ligament latches to lateral uterus. Okay, so it latches to lateral uterus. Where is our ovarian ligament? I don't think it's, yes, there it is. So it connects the ovary to the uterus. We have done infundibulopelvic ligament that connects the ovary to the lateral pelvic wall. We have done the ovarian ligament that connects ovary to the lateral uterus. We have done round ligament of uterus that connects the uterine fundus to labia majora, this big ligament, and it travels through the inguinal canal, round inguinal canal. We've done the broad ligament that connects the three structures to the pelvic side wall, and we've done the cardinal ligament that connects the cervix to the side wall of the pelvis, and its ligation causes the ureter to be at risk of injury during hysterectomy. Cardinal ligament. That is why it is cardinal, because it causes the ureter to be at risk. So these were it. Now we go to reproductive epithelial histology. The tissue vagina has stratified squamous epithelium, non-keratinized. Ectocervix is stratified squamous epithelium, non-keratinized. Transformation zone has squamocolumnar junction, most common area for cervical cancer. Okay, so this is very high yield. The most common area for cervical cancer is the transformation zone, and it has squamocolumnar. So it is squamous as well as columnar because there is a junction between the ector of cervix, which is stratified squamous epithelium, and the endocervix, which is columnar epithelium, simple columnar epithelium. So the transformation zone, which is the most common site of cervical cancer, is squamocolumnar in histology. The uterus is simple columnar epithelium with long tubular glands in follicular phase, quiet glands in luteal phase. Long tubular glands in follicular phase and quiet glands in luteal phase. Fallopian tubes is simple columnar as well, and ovary outer surface is simple cuboidal epithelium. That was histology. So, from bottom upwards, the vagina and the ectocervix are like stratified squamous epithelium. Then there's a junction, and after the junction, the endocervix and the rest of the uterus and the fallopian tube are simple columnar epithelium, and the ovary is simple cuboidal epithelium, germinal epithelium covering surface of the ovary. So yeah. Female sexual response cycle, most commonly described as phase of excitement, uterus elevates, vaginal lubrication, plateau, expansion of inner vagina, orgasm, contraction of uterus, resolution, mediated by autonomic nervous system, also causes tachycardia and skin flushing. So now we are moving to the male reproductive anatomy. This is the male reproductive system, and these are the testes, which are the gamete-producing organs. From bottom upwards, we have the scrotum. The scrotum contains the testis and the epididymis. Then we have the penis. It has a gland, a prepuce, and a shaft, and a urethra. And this is the bone symphysis pubis right above the penis. Then we have the Cowper's gland or bulbourethral gland, the ejaculatory duct, which is originating from the seminal vesicle, and then we have the ureter inside the prostate gland, I think, and this is the vas deferens and the bladder. Yes, this is the prostate. This is the um, ejaculatory duct, which is going through the prostate, originating from the seminal vesicle, and this is the bladder and the ureter, which is going inside the bladder, and the vas deferens, which is coursing in this way to the epididymis. If we zoom in on it, then we have this structure, which is head of epididymis. This structure, this head of epididymis. Then we have the septa, the seminiferous tubules. Okay, so seminiferous tubules are right here, and seminiferous tubules combine to form the septa. And it was covered by Tunica albuginea. And then as there was a head of epididymis, there's also a tail of epididymis. And all these structures, the septa and the seminiferous tubule drain into the rete testes, which is this area, and the rete testes then drains into the epididymis, and the epididymis then drains into the vas deferens, and the vas deferens then drains into the ejaculatory duct, and the ejaculatory duct then goes to urethra, and then the penis, which is 7 up, the pathway of sperm during ejaculation. The first one is seminiferous tubules, then it is the epididymis right here, and then it is the vas deferens right here. So it is doing it in this way. Wait. Seminiferous tubules, epididymis, and then the vas deferens all the way up there, like all the way up there. And then there is the ejaculatory duct, which comes right here. And then comes the urethra, which is right here, like coursing this way. And then there's the penis. So 7. Urethral injury is suspected if blood is seen at urethral meatus. Posterior urethral injuries and anterior urethral injuries are there. Posterior urethral injury, membranous urethra prone to injury from pelvic fracture. Bulbar urethra, susceptible to blunt force, and injury can cause urine to leak into retropubic space. Okay, so there's posterior urethral injury, which can be because of membranous urethra and bulbar urethra. I'd like to emphasize the parts of urethra here. So there is a pre-prostatic part of urethra. There is a pre-prostatic part of urethra, this part, then there's a prostatic part of urethra, then there is a membranous part of the urethra outside the prostate gland, and then there's a spongy part of the urethra, also known as the bulbar part of urethra. So what they're saying is, in posterior urethral injuries, membranous urethra is prone to injury from pelvic fracture. Um, Wait, membranous urethra is prone to injury by pelvic fracture, this part. And the bulbar urethra is susceptible to blunt force. So this part is susceptible to blunt force, and injury can cause urine to leak into retropubic space, which is the space behind the, wait, I'll search that as well. Retropubic space. So, retropubic space is, this is the bladder, this is the urethra, and this is the prostate. And this has to be the retropubic space. The star is the between the bladder and the pubic symphysis. This is the retropubic space, so the urine will drain into here and not into the urethra as normally it does, because this is the prostate and this is where the membranous urethra will originate. And if there is an injury to membranous urethra or the bulbar urethra here, the urine will pass into this retropubic space. Anterior urethral injuries are penile urethra at risk of damage due to perineal straddle injury. So, penile urethra, this part, penile urethra is at risk of injury due to straddle injuries. This is very important and can cause urine to leak beneath deep fascia of buck. If fascia is torn, urine escapes into superficial perineal space. So, the deep fascia of buck. This is the Buck's fascia, and for anterior urethral injuries, the penile part is at damage, and the urine can leak beneath the deep fascia. And if the fascia is torn, urine escapes into superficial perineal space. Let's see what the superficial perineal space is. Superficial perineal space in male. Okay, so all of these, the location of the penis and the bladder is in the superficial perineal space, so the urine leaks there. It leaks into retropubic space in posterior urethral injuries, and it leaks into deep fascia of buck or superficial perineal space in interior urethral injuries. Anatomic innervation of male sexual response is erection, which is by parasympathetic nervous system, pelvic nerve. In this process, there is nitric oxide, which causes increase in cyclic GMP molecules, which causes smooth muscle relaxation and vasodilation, and this makes it pro-erectile. And norepinephrine that causes increase in calcium intake and the smooth muscle contraction, vasoconstriction, and it makes it anti-erectile. So norepinephrine is anti-erectile and NO is nitric oxide is pro-erectile. Emission is by the sympathetic nervous system. Point erection, P, and shoot, emission, sympathetic nervous system, hypogastric nerve, and ejaculation is by visceral and somatic nerves, such as pudendal nerve. PDE5 inhibitors, examples of sildenafil, decrease CGMP breakdown. PDE5 inhibitors, examples of sildenafil, decrease CGMP breakdown. This is particularly important because if the CGMP breakdown is decreased, they can be increased CGMP and the erection can be maintained. Next are the seminiferous tubules. They have cells, spermatogonium germ cells, Sertoli cells, which are non-germ cells, and Leydig cells, which are endocrine cells. So here is a diagram of the seminifers tubules. Um, this is the lumen of seminifers tubules. This is the spermatozoon. These are the spermatids. This is the spermatocyte. This is spermatogonium. Um, it goes from spermatogonium to spermatocyte to spermatozoon and then spermatids. This is the process of spermatogenesis happening here. This is a Sertoli cell nucleus, and these are androgen binding proteins. And this is a Sertoli cell, this black thing, I think. And this, well, that is a nucleus and that is a Sertoli cell, I'd say. And the hypothalamus causes gonadotropin-releasing hormone to be secreted and act on the anterior pituitary. This secretes luteinizing hormone, follicle-stimulating hormone. Follicle-stimulating hormone goes and activates the seminiferous tubules. Luteinizing hormone goes and activates the Leydig cells to secrete testosterone, which acts and causes proliferation of the seminiferous tubules and the lumen and the androgen binding proteins to be activated. And this testosterone and luteinizing hormone inhibit the hypothalamus. Okay. So, there's also a histological diagram of the lumen of the seminiferous tubules, secondary spermatocytes, spermatids, primary spermatocytes, spermatogonia, and Sertoli cells, and the seminiferous tubule and interstitial cells are bleeding. You should know that they are placed outside the seminiferous tubule. So, spermatogonia or germ cells maintain germ pool and produce primary spermatocytes. They line the seminiferous tubules. The A star, spermatogonia, these cells, they line the seminiferous tubules and they produce primary spermatocytes. The spermatogonia produce primary spermatocytes and then their secondary spermatocytes. All right. So Sertoli cells are non-germ cells. They secrete inhibin that inhibits FSH. So Sertoli cells are non-germline cells and they secrete inhibin that inhibits FSH right here. They secrete androgen binding protein that maintains the local level of testosterone. They form tight junctions between Aegis and Sertoli cells, form blood-testis barrier, which isolates the gametes from autoimmune attacks. So they have an role in immunity, role in inhibiting FSH, role in maintaining the levels of testosterone. They support and nourish developing spermatozoa. They regulate spermatogenesis. They produce Mullerian inhibiting factor, which prevents the development of paramesonephric ducts and the female reproductive system. They are temperature sensitive and they decrease sperm production and decrease inhibin with increase in temperature. They also line the seminiferous tubules and convert testosterone and androstenedione to estrogens via aromatase. Sertoli cells support sperm synthesis. They're homolog of female granulosa cells, and increased temperature is seen in varicocele and cryptorchidism. So there's increased temperature seen in them, and there's decreased sperm production because of decrease in inhibin, because Sertoli cells are temperature sensitive. So they secrete inhibin to inhibit FSH. They secrete androgen binding protein for maintaining levels of testosterone. They form a blood testis barrier for protecting the gametes from an autoimmune attack. They support and nourish the developing spermatozoa. They regulate the spermatogenesis and they produce MIF. Lastly, there are Leydig cells or endocrine cells that secrete testosterone in the presence of luteinizing hormone. Testosterone production is unaffected by temperature. So this is an important point to note that the sperm production decreases because of decrease in inhibin, which is because Sertoli cells are temperature sensitive and inhibin is produced by Sertoli cells, but testosterone production is unaffected by temperature because it is being produced by luteinizing hormone, and Sertoli cells only maintain the local levels of testosterone and they have no role in direct production of it. They do convert testosterone and androstenedione to estrogens via the aromatase enzyme. So Leydig cells form the interstitium and they are the homologue of female theca interna cells. Sertoli cells are the homologue of female granulosa cells, and granulosa cells produce estrogen, I remember, and Leydig cells are the homologue of female theca interna cells. So that was about our reproductive anatomy. I hope you could learn something, and let's meet in reproductive physiology. Thank you so much for watching.